de ustedes me conocen, otros no. Yo soy Darío, el presidente de la Asociación de la Argentina. Así que es un gusto convocarlos para esta actividad que tiene como objetivo que la población o la comunidad afectada por ELA en nuestro país tenga la posibilidad de tomar contacto directo con los máximos referentes en la investigación de ELA en el mundo, y así poder tener nosotros la información, el tratamiento de la ELA y el estado de la investigación. La verdad que es un honor para nosotros poder acceder a esto. Quiero valorar a Pablo durante 7, 8 años, que junto conmigo hemos viajado por diferentes lugares del mundo para tener la legitimidad necesaria como Asociación de la Argentina y poder tener el vínculo directo, afectivo y muy valioso con los máximos investigadores en el mundo de la ELA, cuestión que cuando nosotros nos juntamos para hacer la Asociación de la Argentina hace unos años atrás, muy pocos, cuando nuestros seres queridos estaban padeciendo la enfermedad, en el caso mío, mi papá, en el caso de Pablo, su hermano, no teníamos acceso absolutamente a nada, y ni a nadie, ni siquiera conocíamos el mundo de ELA tal como viene reuniéndose durante tantos años. Con lo cual, dicho esto, lo que quiero decir es que valoremos muchísimo, muchísimo este acceso a la información y al contacto directo con los máximos investigadores de ELA en el mundo. Bueno, les doy la bienvenida a todos. Pablo va a ser quien va a moderar todo esto y les va a explicar nuevamente cuál es la modalidad. La profesora HArdiman, obviamente, es una persona que vive en Reino Unido, en Inglaterra, en Irlanda, y lamentablemente, bueno, no hablamos el mismo idioma, por lo cual tuvimos que realizar una experiencia diferente y pensar una modalidad que nos va a ser muy útil a todos y a las miles y miles de personas que van a tener el acceso a esta información y a esta aula virtual una vez que editemos todas nuestras preguntas, inquietudes, sugerencias y tengamos las respuestas por parte de la profesora y obviamente el subtitulado al español. Y esto va a explayarse a toda la comunidad internacional de habla hispana y seguramente habrá decenas de miles de personas que lo van a ver y nosotros vamos a ser los protagonistas de este interrogatorio. También sé que Silvia y Sofía estuvieron trabajando en la inscripción de esta aula virtual y les han ofrecido a ustedes un link con un video de la profesora HArdiman en su última exposición en la Alianza Internacional de Asociaciones de ELA en Glasgow en el año 2018, como para que conozcamos un poco cuál es la idea y los conceptos básicos de ella respecto a lo que tiene que ver con la investigación, y en el caso que una pregunta esté también considerada en relación a esa visión que tiene ella en torno a la investigación y al optimismo en cuanto a hallar en algún momento una solución a esta enfermedad que nos aqueja a todos. Dicho esto, yo no hablo más, los dejo a ustedes y bueno, lo dejo todo en manos de Pablo. Un beso y un abrazo para todos y los escucho. Gracias.
So, as I was saying, maybe you can start by shortly explaining what's the situation like, not only in Ireland, in Europe, because you are with the ENCOS organization. So how is the COVID-19 pandemic affecting the trials that are going on in Europe right now?
Yeah, so the COVID-19 has had a very major effect in Europe on both the delivery of services and also our ability to recruit and retain patients in clinical trials. This is also true in the US, by the way. Yes. So the pharma related studies that are currently underway, it's variable across different countries. The C9orf antisense oligonucleotide studies are underway. The centres that are in the earlier cohorts of those studies are continuing to recruit, even in the very badly affected countries such as Italy. So that's good news. We're in cohort 5 for that study, and we have had some difficulties because we're in lockdown in Ireland, and that's made the final review of our sites by our regulatory authorities challenging. So we're hoping to have that resolved in the next couple of weeks. The trials that we have, some trials that are investigator-led. We have a European Union funded study, and that's currently still recruiting, but with some modifications. The main difficulty that we have in trials are the types of measurements that we undertake. So the outcome in many clinical trials includes forced vital capacity, so blowing into a machine with air blowing out. And that is considered to be a significant risk in a COVID related world, because if a person blows out, they're blowing the air out in the entire space around them. And if that person is carrying COVID, it puts everybody else at risk in the room. So this is a problem that that has led to many difficulties across the world. The healthcare professionals who are engaging in these studies would need to wear protective equipment in order for us to be able to do that. So there, both in the US and also in Europe, there are revisions being undertaken to determine whether there are other measurements that we could use in addition to vital capacity that might be as good as vital capacity as a measurement. So that's a problem at the moment. So we in Ireland have been doing that, where our team, our clinical trial team, are using the correct equipment, and we can assess people and use the vital capacity measurements. But it's more expensive, and it takes more time, because we have to have the person in a separate room, and then we have to clean the room. So this is a problem, and I think it'll be a problem going forward. So trials are underway. Some trials the very important trials, like the gene therapy trials, are underway. But I think we will have to think carefully about future trials and the types of outcomes that we might want to measure, because the COVID pandemic is not going to go away for some time, and until we have a vaccine, it's going to be challenging. The second problem is that our patients in Ireland and across Europe have been, the countries have been very badly hit by COVID, and the advice to people who have chronic illness and who are vulnerable is to what we would call cocoon. So that means staying at home and not going out and not seeing anybody. So patients are very worried and frightened about coming to hospitals where there is COVID. So that also is a problem. We need to be able to ensure that the environment where people are evaluated is safe, and we need to be able to assure them that the environment is safe as well. So these are challenges that we're all encountering across Europe.
Ahí veo una mano levantada. Vamos a ir con Olga Cosentino.
Quiero saber si, en vista de la actual pandemia, hay ya alguna estadística acerca de si este virus, afectando a un paciente con ELA, tiene aumentadas sus capacidades de letalidad o su virulencia?
Right, that's a really good question, and the answer is nobody knows. But we actually had a discussion across Europe about this quite recently. So patients with ALS are generally, if they're a little bit more disabled, it's more difficult for them to get out, and so their risks of contracting or getting coronavirus are probably a little bit lower than the general population. But obviously, if somebody gets somebody with ALS who has some breathing problem gets coronavirus, that makes it a little bit more challenging. We're not aware that ALS per se, the disease ALS, specifically increases the risks of getting coronavirus. So, having ALS doesn't necessarily make you more or less likely to get ALS. but it creates complications if you're using NIV, because again, the air is being blown out, and if you get coronavirus, everybody in the room will be exposed to the virus. So that's a big problem. So the other risk is age. So if you look at the data for coronavirus, the risks for people dying goes up a little bit at 60, and it goes up a lot at 70. And so being male and being over 70 are two significant risks for having a severe form of coronavirus. So that they're the population that have ALS, unfortunately. On the other hand, the other two risks that we see for coronavirus ALS patients tend not to have, one is the risk of obesity. So that's a particular risk for ALS, and ALS patients are not obese usually. So we don't know why that is. So the answer is the risks are not that much higher that we can see compared to the population at the same age. But if a person gets coronavirus, then that's a problem if they're using NIV.
La investigación sobre Neuron prometían resultados para 2020. ¿Se mantiene ese pronóstico en cuanto a los resultados?
So we didn't do the Neuron trial. It was mostly in the United States. So I looked online to see if I could find any report of that, and I haven't. The phase 2 trial, as you know, was reported, but phase 2 trials are really about safety, and we can't really make any comments about whether a trial in phase 2 worked or not. So I think I haven't seen any report from the phase 3 trial as of yet. I would imagine we would have seen that at the International Symposium, but unfortunately that's been cancelled in Montreal. There will be a virtual symposium, so I expect we will hear about that virtually, but I haven't seen a report of that, and I'm not a principal investigator, so I wasn't involved in that study.
So what can we say about the current stage of Neuron, the Neuron trial?
The Neuron trial is in phase 3, so it's in the last stage of development. I think we can say that we don't know if it works or not. We'll learn that at the end of the trial. We have published the early phase trial after one dose, and we can say it's safe, and it has some good biological effects. It lowers markers of inflammation, and at least for a short term, it seemed to maybe have some hints of clinical efficacy. But we don't know long term if that will continue, and we don't know if it will, bear out in everybody.
And when can we expect next results, next data?
I think in about a year. The enrollment's done, so now we have to wait until the last person finishes the study.
Okay.
¿Qué tal? Buenas tardes. Bueno, mi nombre es Martín Baulo. Primero, gracias por esta oportunidad. Para nosotros realmente es muy valioso poder tener esta posibilidad, ¿no? de plantear todas nuestras inquietudes. Tengo varias preguntas. Una es en relación a lo que consultaron recién, en lo que es terapias, la terapia con Neuron. En principio, consultar si todo este tema de la pandemia afecta, el cronograma con todos los protocolos que se estaban llevando adelante hasta ahora, y si, en función de esto, no sé, va a haber un retraso, ¿no?, en los anuncios que se iban a hacer.
I think the big issue is going to be outcome measures, and we've had a number of international discussions, and there's another one scheduled sometime in the next few weeks, to determine whether we have other outcome measures that could be used along with forced vital capacity, or whether there are ways by which we can continue to measure forced vital capacity in a way that gives us reliable answers, because of the risk of this blowing air into the space where the investigators are as well. So we haven't come to a conclusion about that, but this is something that is is probably going to be the subject of a discussion across the world. We've been discussing this with all of the principal investigators in the US, Canada, Australia, and Europe. We've had some discussions already online about this.
Yo no sé bien cuáles son los cronogramas que habrían, ¿no? Durante este 2020, vos recién comentabas que era un año muy esperanzador. La verdad que no sé si hay disponible algún calendario con las drogas y los tratamientos que se iban a anunciar, que están en fase 3, que tenían pensado justamente anunciar durante el transcurso de este año. Y si eso, bueno, en función de todo este problema con la pandemia, se va a dilatar o a demorar.
Okay, so that's easy. That's clinicaltrials.gov. So it's a US site that is a repository for trials. If you go onto that, there are hundreds and hundreds of trials, both small and big. The difficulty, of course, is that many trials are small and recruiting in restricted areas. And the decision about where trials are undertaken, if they're sponsored by industry, is an industry decision. So countries in Latin America or smaller countries like Ireland, we sometimes are not included in those trials for logistic, financial or commercial reasons, and that can be very frustrating for people. So if we want to know in general what's going on around the world, that site is really good, but if we want to know what's going on locally in our own countries, the best way to stay in touch is to stay in touch with the local ALS clinics within our own countries, because they are linked in with all the centers around the world as well.
Después consultar también en relación a las terapias antisentido, si este tipo de tratamiento que estaba orientado solamente a un subgrupo de pacientes con ELA estaba pensado también para la totalidad de los pacientes, y esto, digamos, se puede llegar a pensar en incluir a todos los pacientes con ELA.
Yeah, that's a really good question, and the answer is we don't know. So antisense therapy is it's really exciting. It's a really exciting new approach, and the first studies are currently being reported for SOD1. So these are only patients who have known mutations in the SOD1 gene, and that's fairly uncommon. So I don't know if we know the frequency of SOD1 mutations in Argentina. I know in some parts of Latin America it's much rarer. For example, we've looked at it in Cuba, and there aren't any known SOD1 mutations in Cuba. It's a common mutation in the United States, or common gene with mutations. In Italy, for example, it accounts for about 13% of familial ALS. But this is quite variable around Europe. For example, we don't have any patients in Ireland with SOD1 mutations. So the SOD1 trials are currently underway. The phase 1-2 trial is being reported as we speak. It's been submitted for publication. There's a phase 3 trial ongoing, and the preliminary data that we've seen looks very promising. The next set of antisense oligo studies are the ones for C9orf72, and they're currently enrolling, and it's done in the same as the SOD1 by small groups of patients with different dosages. So we haven't seen any results from those studies yet. Then there will be new studies with another gene called ataxin-2, most likely. Whether these treatments would be of benefit in general non-genetic ALS, we don't know. Most unlikely for C9orf72. For SOD1, it's very debatable. There are some data, there is some evidence to suggest that perhaps even in people who don't have the SOD1 gene mutation, that the SOD1 protein might become abnormal in some people with ALS. And if that were the case, you could imagine that treating to stop the SOD1 protein from being produced might be helpful. but we don't know yet. It's purely theoretical. So at the moment, those treatments are only for people with the gene abnormality. And unfortunately, they won't be for people who don't have that gene abnormality at the moment. But it's still really exciting because it means that we might, for a small percentage of people, we might actually have a treatment that makes ALS stabilize. And that's really exciting. And it's the beginning of a new era of treatments, I think.
Yeah, it's a start. And just a short note on Argentina, we don't have a proper registry of ALS patients here. We try to do something like that with our association and the previous government, but that was suspended when the government changed in 2015. And we do know about a couple of SOD1 cases, and you could expect that you can find some cases in Argentina because about 90% of the people in Argentina has European descent, which makes it a bit different from the rest of Latin America. So and we still, I think one of the highest notes outside the symposium, but one of the highest notes in Perth when was Amar Al-Chalabi said that we may find a cure for SOD1 in 1 year. And everyone was like, what? In 1 year?
For 2% of people who have SOD1 mutation, antisense therapy is around the corner, and we may have a cure in a year or less. If you're talking about a cure for everybody, that's a very different thing.
So that was a bit bold from him, but we know him, we know Amar very well, and we know that he doesn't say something if he's
so
not
I
sure
think a cure might be a little bit of a stretch. I think what we'd really like to see if we could stop it progressing. So curing makes it go away. I don't know if that's true, but if we can stop the disease from progressing, I think that would be really good as well. But I think we'll have to wait and see the results of the trial about how much benefit this treatment provides. I think it definitely makes a difference. We've seen the early data, but I think where it goes from there, I think we'll have to wait and see.
Dos preguntitas más. Una tiene que ver justamente con el video que habían mandado la vez pasada en relación a la exposición de la doctora HArdiman, en donde ella hablaba de medicina de precisión, que bueno, esto tiene 1 año y medio más o menos, y digamos, en relación a esto que tenía que ver un poco con la posibilidad de dividir, ¿no?, los pacientes de ELA de acuerdo a determinadas características en subgrupos, y orientar estos estudios específicamente a cada uno de estos grupos, ¿no? Orientar, digamos, la posibilidad de lograr alguna droga en relación a estos subgrupos. Si había habido, digamos, algún avance en este sentido, ¿cuáles eran, digamos, los subgrupos en los cuales por ahí se había podido avanzar con algún tratamiento, y para cuándo podría haber por ahí alguna novedad, ¿no?
Well, the first update is the SOD1 trials and the C9orf72 trials. So precision medicine is tailoring the drug to the particular patient. So, and that means both their genetic profile and their clinical profile. So we need to obtain as much information as we can about the patient in order to do that. So the easy part of that in one way is if we have gene therapies that work. So that's the first update. Then there's a study that we're just about to start in Europe, where we know that there's a gene called UNC13A, and we know that if you have a particular variation in that gene, we can give you lithium, and it is likely to slow down how the disease progresses if you have that particular variant. So we're just about to start a study in Europe to test that, to see if that is indeed the case. So that's a form of precision medicine as well. We're also just about to start a study in Europe based on the idea that some types of ALS may be related to viruses that are embedded within our genetic structure. And we have a drug that works against these types of viruses that's used in HIV, and we're just about to start a study in patients to test that. Now we don't know if that's everybody or if that's only going to be some patients. So we will be checking to see if the drug works and if there are certain subgroups of patients that will respond to a greater extent than others. So the study will be set up and designed for that. And we'll have markers to see if there is a response related to having that virus code within our genomic structure. So that's going to start later this year. Then I think that we will have to learn a bit more how to segregate patients, how to separate patients into different subgroups that are not just based on genetics, but maybe based on other aspects of their diseases. So we're not there yet, but I think in the next few years we will be able to do that. So our own work in Dublin, which is also now underway in Utrecht with Leonard Vandenberg's group, we're using network analysis, so measuring the brain networks using electrical recordings of the brain to separate patients into different subgroups. And I think that might be a way as well of identifying subgroups of patients, and certain drugs might work better in those groups of patients. So it's a work in progress at the moment, but we're definitely sure that that this is the way we should be going. I have to also, I suppose, mention some work that is underway in the Citran Centre in Sheffield with Professor Dame Pamela Shaw's group, where they're taking pieces of skin and growing the piece of skin into cells that are like the cells that we see in the nervous system. And the group there has shown that there are differences in the way these cells respond. Different patients have different responses in these cell groups that tell us that certain drugs might work and certain other drugs mightn't work. So that's laboratory work, but it's really human-based laboratory work. So it's not animal work. So this is probably work that we could translate back into people much more effectively. So that work is very early, but there are certain drugs that we think might work in certain subgroups of people using this, what we would call readout from the cells that are grown in the laboratory. These what they're called iPS cells. These are cells that are made into stem cells and then returned into cells from within the nervous system. So that's really exciting work as well in the Citran group in Sheffield. And I think that will lead to future therapies as well. There are certain drugs that group is looking at that we might be able to bring into the human, into clinical trials in the not too distant future. So that's really exciting as well.
En el caso de mi papá, él actualmente está con edrabone. Digamos que si se puede mantener todas las drogas, es decir, si van a ser todas las drogas compatibles, o si va a generar tener que dejar de lado, por ejemplo, el riluzol, el edrabone y todo eso, para poder probar la droga nueva. Básicamente esto, que si tienen cierta compatibilidad o no, o se hace un cóctel o se hace por separado, esto.
Yeah, we have quite a few patients here taking edaravone already, so they are concerned about that, and they most of them are taking riluzole as well, of course.
Yeah. So from an ethical point of view, all across the world, it's not considered ethical anymore to not use riluzole. So in trial design. Well, that's not quite true, but in most centres, in trial designs, we normally have riluzole and another drug added on, and then riluzole and the placebo. certainly that's the case across Europe. It's not necessarily the case in the United States because riluzole isn't available to everybody in the United States, and I'm not so sure about Latin America. But all the studies that we design, patients are on riluzole, and then the other drug is added to riluzole. With respect to edaravone, that's a little bit different depending on which country you live in. Edaravone, as you know, is available and licensed in the United States, and it sounds like it's also available in Argentina. But the European regulatory authorities did not support the use of edaravone in Europe. So we don't have edaravone available and reimbursed in European countries. It is possible to get edaravone, but the patient usually has to pay for it themselves, and it's expensive. So in Europe, this doesn't apply, but in other countries, particularly in Argentina, United States, the studies are designed to include edaravone as well. There is a possibility of a trial with edaravone in tablet form, which may commence later this year. It's not entirely clear yet whether that will be the case, but using a much longer trial design, much more than 24 weeks, and looking at outcomes, both about whether the drug changes the disease slope, the way how quickly people are becoming worse, but also whether it changes how long people live for. So this is currently in design phase. It hasn't been fully the protocols haven't been fully completed as of yet, but that's certainly in the planning stage at the moment. So that's a tablet form of edaravone rather than an IV form.
Respecto a esto mismo que estás diciendo, de que existe la cura, de que existe la posibilidad de la cura para un subtipo de ELA, ¿cómo identificar qué tipo de ELA es el que tiene nuestro familiar?
So that's a big question, and it's actually going to be a topic at the EAN, the European Academy of Neurology, which is also cancelled. Actually, it was supposed to be in Paris next month, but it's going to be virtual now, and we will have a debate about how much genetic testing we should be doing in a clinical setting. So the difficulty is that there are lots and lots and lots of genes that might be important in ALS, but of the genes that might be, we know for definite that there are only a small number that are common in our populations, anyway, in populations that are from Europe. So these are SOD1, C9orf72, TDP43, and FUS. And then there are other rarer genes that are uncommon, or maybe only in some parts of the world. Some genes in North Africa, for example, or some genes where you need two bad genes to get the disease. Another problem is that if because our genetics are very variable and different populations have different patterns of gene profiling, we don't always know for sure if you have a slight change in a gene, whether that's really related to the disease or whether it's just a rare variant that doesn't really do anything for you. And it's also the case that many genes, many forms of ALS, and probably in fact the vast majority of ALS, are related to not just one gene, but many genes that work together, small effects that work together to increase our risk of developing ALS. And we know that because we know that if you look at whole populations of people with ALS, and this has been done in Europe, it's been done in Australia, and it's also just recently been done in Asia, in Japan and China, and Malaysia, I think. That there are 6 steps to developing ALS. If we just look at this mathematically, 6 things happen to you, and one of these is our genetic makeup. But there are other steps. Then, if we have a gene, for example, an SOD1 gene that we know really causes the disease, and there are some variants in the gene that we know really cause the disease, that reduces maybe to 2 or 3 steps, but you still have to have something else happen to you as well. In C9orf, it's about 3 or 4 steps. So even then, with those genes, we still have to have something else happen to us. So the answer to the question is the subtype of ALS that a person has. We have a lot of work to do to understand that. That is a question about precision medicine. It's a question of, what type of ALS do I have that would respond to what drug that you might have for me? And we're not quite there yet, except for the ones where it's a really easy answer because you have a gene defect. So I think the answer to the question is work really closely with your centre with ALS. Participate in all the studies that we're doing to try and understand this disease so that we have as much information as we have in as many patients or people with ALS that we can find, so that we can do lots of studies to try and understand this disease with not just clinical but also genetics and other things that we do as well. In Ireland, we do family history, we do imaging, we do brainwave analysis. We're just starting to do this IPS cell. Other groups are doing that as well. So there's lots and lots of things that we need to do to understand this disease and to be able to separate it out into different subgroups that might then predict what drugs are going to work on whom. So it's a long answer to a short question. The short question is, if it's genetic, it's a little bit easier. If it's more than one gene, and we know that accounts for maybe our risks are about 50% of our risk is genetic, lots of different genes. We're not quite there yet, but we're not that far away yet either. And I think the next few years will be much better at being able to answer that question in a much better way. I think we should think about things like cancer from that point of view. Cancer is about 10 years or 15 years ahead of us because they can subgroup lots of different types of cancers and define then which drug is going to work in which patient. So we need to get much better at subtyping. We can't take the brain or the spinal cord out of the person. So we have to find clever ways of studying the brain and the spinal cord in people with ALS. And there's lots of new technologies there that are beginning to be able to do that.
Would you recommend someone with ALS to send their blood to some laboratory to at least find out if they have one of the known genes like SOD or C9?
I wouldn't recommend that a person sends their blood to a lab like 23andMe or just any random lab. I would strongly recommend that the person with ALS work with their ALS physician, and that the study or the analysis of the DNA is done in a research setting, or if there's a strong family history, or if there are other reasons to believe that the person carries one of the known genes, that could be done. That's very variable around different parts of the world. In Ireland, for example, we screen for C9orf72 in people who have a family history of ALS or a family history of dementia, and or if they're under 60 years of age. That's all we do. In some, and that's mostly because of cost and because we know from our research work that SOD1 we don't really have any SOD1 in Ireland, nor do we have any familial TDP43, and FUS is usually not genetic. So of the 4 major genes that we see in European populations, there's only one that's really important in Ireland. In Italy, they screen for the 4 major genes, because they all are present in the Italian population. That may also be the case in Argentina because you have a big Italian population in Argentina as well. So each center, each country needs to tailor what they do in terms of gene screening according to what the likely profile is in their country, and also what difference it might make. So up to very recently, we didn't really screen at all in Ireland because there wasn't going to be any difference that this made to our patients. We had no treatments. So knowing that you carried a gene wasn't going to necessarily change how you engage with your disease. And it raised all sorts of questions and problems for the next generation. So we only started screening in Ireland when we had the possibility of a treatment. Now, that's a particularly cultural position that we take, and other centres are different from that point of view. But to answer the question about whether you should send your DNA off to be screened, I would caution against that, because the analysis or the interpretation of the genetic profile needs to be undertaken in the context of the genetic background that you come from and the environment that you live in. So that's really important. So it may be, if you're a native Amerindian and you're living in Argentina, your genetic profile might be quite different, and you might have some variants that we don't see but that are common within the particular genetic background that you come from, and so we could get a lot of false positives there. So we need to be really careful, and the analysis has to be taken in the context of the background genetic epidemiology, the genetic structure of the population from which you come.
Yo lo que quiero saber es si estudiando, ponele a mi hermana, que no sabemos porque ella nunca se hizo un estudio genético, y a nosotros, los hermanos que no estamos afectados, si de eso se puede llegar a la detección de diferencias significativas entre nosotros que no la padecemos y mi hermana que sí, porque mi mamá no sabemos qué gen tenía o si tenía un gen afectado, ¿entendés?
Okay, so that's what I was going to say. So if there's one person in the family who's ALS, the probability of anybody else getting ALS in that family is not that much higher than the general population. So because the lifetime risk in European populations of developing ALS is about 1 in 400. So if you, for example, have 18 members of your family, there's a 5% risk that one person in your family will have ALS just by chance, or another person. So if there is only one person in your family with ALS, the likelihood of this being familial ALS is not that much higher than the general population. If there are more than 3 people in the family with ALS, then the likelihood is higher that this is a genetic form. But even then, it's not clear that even if you carry a genetic variant, it's not definite that you will get the disease. So whether we should screen people who don't have the disease for genetic forms of ALS is very controversial, and the recommendation would be that we should probably not do that except in a research setting. We should only be doing that as part of a centre that's engaging in ALS research. And that's because it depends on the gene variant. So there are some genes, C9orf being one of them, where you can carry the gene and you don't necessarily get the disease, and we don't know what the probability is that you will get the disease with C9. On the other hand, if you carry an A5V mutation in SOD1, which is an American mutation actually, it comes from the Native American population in the United States, that gene pretty much gives you ALS. You pretty much will get ALS if you have that variant in that gene. So there's a lot of variation, a lot of variability, and it's very difficult on an individual basis to counsel somebody. So to answer the question about the person whose mother or father had ALS, whether they should have the gene test without having any ALS symptoms, I would recommend no, unless they're part of a research group, unless they're part of a research study, because the advantage of knowing that is not very good. The disadvantage of knowing it are very high, and unless they're being studied as part of a research group, it's probably not a good idea.
Yo trabajé 22 años en la industria automotriz, ¿me entendés? Y bueno, y siempre se hace mucho hincapié en la ciudad, viste, cuando se coloca una antena de teléfono celular por el tema de la radiación y todo eso. Donde yo trabajaba, en la planta de carrocería de la fábrica que está acá de automóviles, o sea, la carga genética, la carga electromagnética de una antena esa de celular era una escarbadienta a comparación de lo que había. Era una planta donde había miles de robots, miles de transformadores y que obviamente había cartelería por todos lados que no podían transitar personas con marcapaso y algunos de los instrumentos. Yo no sé si a mí, yo obviamente creo que fui el único caso que se registró en estos 22 años con ILA que salió de la fábrica. Pero yo no sé si ese factor ambiental, como el que están nombrando vos, ha sido por ahí un desencadenante.
Yeah, it's a really good question, and I think the answer is in the question, which is that nobody else in the factory got ALS. So we know that because about 0.53 of 1 or about 53% of the risk of ALS is probably genetic and the rest is environmental exposure, that probably, interactions between genes and environments are probably important. And we also know that in some cases there is some evidence at population level that certain exposures in large groups are a little bit more common. And some of those include some types of pesticide and possibly some electromagnetic radiation. But that's at group level. So bringing that back down to any one individual is impossible to do. So the answer is we don't know. The answer is people get ALS and it's some interaction between their genetic structure and things that happen to them in their life. But at an individual level, that's almost impossible or is impossible to make a statement about that. So I can understand the question, but the answer is that it's not possible and it's scientifically incorrect to draw a conclusion from a study that we do in large populations to an individual. It's not possible to do that, scientifically not possible to do that.
Mi pregunta sería, bueno, qué sé yo, ¿qué tipo de ELA tengo? ¿Cómo puedo saber qué tipo de ELA tengo? Yo sé que mi voz ha ido cambiando en este último tiempo, entonces eso como que me da un poco de susto, la verdad que te asusta porque yo digo, pucha, si me quedo sin hablar, no tengo fuerza en las manos, no puedo ni siquiera comer solo, ahora encima esto. Entonces, bueno, me gustaría saber eso, qué tipo de ELA tengo y para ver las posibilidades de entrar en algún programa de terapia alternativa o algún programa que todos los científicos que están estudiando nuestra enfermedad lleguen realmente a una cura que sea algo positivo o esperanzador.
Okay, so what type of ALS a person has, it depends on how you define that. So I get asked this a lot in my clinic as well, because you look on the internet and it says, oh, there are 4 types of ALS, and then you look at other things and they'll give you different, find the Ellis score criterion, that'll give you a different set of things that, so the simple way that we divide ALS is, one way is to say, is it familial or is it not familial? So is it probably a gene that's only in the family, or is it one of these types where we don't see the gene running in the family? So familial or what we call sporadic. That's one way of looking at it. Another way is to say, my ALS started in my leg or my ALS started in my voice. So starting in my leg and my arm is called spinal onset, and starting in my voice is called bulbar onset. And we know that divides also into being male or female. So males are more likely to have ALS starting in their limbs, and a spinal onset is commoner in men, and bulbar onset is commoner in older women. And we sometimes when we engage in clinical trials, we divide people out into whether they have spinal onset disease or bulbar onset disease, because the patterns at a group level look a little bit different. But for any one individual, that's not always the case. There are also 2 other types of ALS in terms of onset. One is called respiratory onset, where the breathing muscles give trouble first. It's very rare. It's about maybe 5% of ALS is respiratory onset. And then there's a proportion of people where the ALS begins with thinking and behavior. So it's a cognitive or behavioral onset. So we didn't really recognize those until quite recently. To my mind, dividing ALS into onset, is something that we can do clinically. But I'm not personally sure how valuable that is. And I think we probably need better ways of subtyping ALS based on some of the things I said, like, whether there's thinking involvement or not, whether there's a gene involved or not, and then other things that we can do using some of the markers that we're going to have going forward. But at the moment, we divided the spinal and bulbar and respiratory onset and cognitive onset.
Te pregunto por cosas que escucho, leo, viste, de terapias
Sí.
alternativas que se escuchan por todos lados, que una de las posibles causas de la ELA puede ser por intoxicación de metales pesados. Yo lo que quería preguntarle a ella, si en los estudios que ella realiza, hay algún hallazgo, porque hay vacunas que tienen un componente, un conservante, que creo que deriva de mercurio, no me acuerdo cómo se llama, si eso sería algo que tenga influencia sobre la causa de la ELA, el componente que tienen las vacunas, algunas vacunas.
No is the answer.
So no study on that.
Well, I mean, I think heavy metal exposure and ALS has been studied and has been considered a possible risk, and the studies that have the sort of very basic studies haven't supported that. So, our ALS patients sometimes read this and they go to their dentist and get the mercury out of their teeth. But there's no real evidence for that to suggest that heavy metal exposure in the way that we think about it is a risk for ALS. There are studies that are looking, for example, at gene-environment interactions with heavy metals, but they're very early and we don't know the outcomes of those. So I think we can say at the moment that a vaccination with a very tiny amount of a substance that stabilizes the vaccine is not going to substantially change the risk of developing ALS.
Siguiendo en el tren de los posibles orígenes, yo de factores de riesgo. Yo cuando te comenté que trabajaba en la industria automotriz, tenía un sobrepeso bastante importante. Pesaba 113 kilos y medía 1,74 m. Entonces, ¿qué pasaba? Conexamente con eso, imagínate mis laboratorios lo que eran un desastre. Entonces fui a una médica endocrinóloga y me dio unas cápsulas, unas pastillas que se llaman Somaritz, de origen alemana, que básicamente eran metformina de 1 gramo, más otra droga que no sé qué era, que era la que me ayudaba a tolerarlo, porque la metformina en dosis tan alta es muy intolerante para el aparato digestivo. Y bueno, también fue justo cuando comenzaron mis caídas, mis tropezones, todo eso. ¿Será o no será? ¿Viste? Pero algo para tener en cuenta. Yo lo pregunté a todos los profesionales neurólogos, me dijeron no, dice no.
I don't know the answer to that. I suspect not, because lots and lots of people take metformin and there's no association between the use of metformin and ALS. And people have looked at drug exposures and ALS risk, and metformin hasn't come up to my knowledge. So I think that's very unlikely.
Isabel es de Tucumán, es fonoaudióloga. Y su pregunta es, ¿qué estudio se debería hacer para tener un pronto diagnóstico sobre esta enfermedad, ya que se realizan varios exámenes descartando otras enfermedades con las que se suele confundir?
So the main ones are the use of neurofilaments in the blood and in the spinal fluid. So they look like they're very useful in patients who have ALS compared to patients who don't. Obviously neurofilaments are elevated in other disease as well, particularly, for example, conditions like MS. So we have to take that in the context of the clinical examination and imaging. But neurofilaments look like they will be very helpful. Then there will be probably imaging tools that we'll be able to use going forward. There are a number of groups using MRI including groups in Italy, in the Netherlands, and in Dublin, where we will have MRI patterns that we might be able to use to help to make a diagnosis. Then there are neurophysiological tools that are being developed. So we use EMG at the moment, where we look at the electrical activity in muscles, and that is very helpful to make a diagnosis of ALS. So that's looking at the degeneration of the nerves in the spinal cord. But there are many groups who are looking at other electrically based tools to try and help us to identify both different types of ALS, both the diagnosis of ALS and different types. So there's a group in Australia that are using something called transcranial magnetic stimulation. So using a magnet to stimulate the brain and then looking at particular aspects of how the brain nerve cells react. And they have some studies that suggest that that's quite useful, although there are maybe some difficulties for other sites to just completely use the same tools that they're using. There are other electrical based studies that we're using in other groups, using brainwave testing, EEG testing, and looking at different patterns of brainwave abnormalities that we might be able to use going forward as a help in making the diagnosis. There are other markers in the blood and in the spinal fluid that are being developed, as well as neurofilaments, but the neurofilaments are the ones that are furthest on in terms of being able to use in a clinical setting.
Más allá de las terapias, después de estar diagnosticado, más allá de las terapias alternativas y fármacos, ¿qué tipo de tratamientos recomiendan para una persona con ELA?
The biggest and most important intervention that we can provide for people with ALS is in managing the changes in breathing. So using the non-invasive ventilation, the mask, is really valuable, and that is the single biggest change in how we deliver care for patients with ALS. The other major innovation, I think, that has significantly changed how we provide care is managing secretions, breathing secretions. So there's a machine called an insufflation, exsufflation, or a cough assist, which helps to manage secretions, and that's really useful and has made a big difference for patients with ALS as well. So secretion management, along with NIV, and then earlier maybe something called breath stacking, where you can help to get a good cough. That's been made a major difference. So working with our colleagues in respiratory medicine to improve how we manage the breathing difficulties with ALS is really important. There are some studies that are looking at things like nutrition. That's really important. There's a study from Germany that's been looking at very high calorie diets and suggesting that that's really useful and beneficial. And also the groups in Oxford, or say in Sheffield, Chris McDermott in the Citran group has also been looking at diet and nutrition. So it looks like maintaining nutrition, maintaining calories, and using really high calorie supplements is probably going to be really valuable and probably makes a big difference as well in ALS. So simple things like not losing weight, keeping the supplements up to a really high level, and managing breathing are the two things that I think have made a big difference in terms of not drug interventions. And then things like helping people to understand the impact of the disease if thinking and behavior are affected, because if thinking and behavior become affected, that can be very stressful, both for the person themselves, but also for their caregivers. So understanding how that might impact on the disease and on relationships around people is really important as well, because that can affect how people access care if their behavior changes and they become a little bit more rude or a little bit more difficult. The nurses mightn't want to deal with them, or they might also engage in risky behavior that mightn't be very good. So understanding that is really important as well, and that can make a difference as well. Understanding that ALS isn't just a condition where our arms and legs and our breathing don't work, but it can affect our thinking and our behavior as well. That's really important. And then simple things like managing the increased saliva, that's really important as well. So the ways we can do that with medication, also Botox can work quite well in that situation to reduce saliva secretion. Managing spasticity with exercises, and also sometimes using a little bit of Botox there can be very helpful as well. So it's really looking at the disease, as the condition as it is moving, and trying to predict what might happen, and trying to put in place both clinical interventions and sometimes drug interventions that'll make life easier and better able to manage. I think the psychological distress is really important as well. So putting in some counselling services to help with what we call psychosocial distress, that can be very helpful as well, and that can make things a lot easier for people as well.
Sobre todo la persona que tiene ELA, de la cual yo me hago cargo, ella descubrió que, o sea, un amigo le dijo de una sustancia que se llama CDS, que sería el dióxido de cloro, y que un investigador alemán, Andreas Kaiker, la está promocionando, y que hay muchísimas personas, bueno, entre ellas una persona de Chile que tenía ELA, la probó y tuvo resultados muy buenos. Entonces yo querría saber qué piensa la doctora de esto, si es que existe esta cosa en el tratamiento, si es posible, si es verdaderamente accesible, y qué opinión tiene ella de esto. O sea, si lo conoce, ¿qué opinión tiene esto?
I worry about individual names promoting individual treatments. I had to look at that. It's a disinfectant. So I don't see any evidence. I mean, there is there's another chlorine-based therapy that has been used in a investigator-led trial setting, which isn't chloral dioxide, and I wonder, are we sort of mixing those two up? But chloral dioxide, I'm not aware of anything any literature on that at all. So I worry about that.
Tengo una pregunta por el chat de María Milian. María Milian está preguntando sobre el eje de las terapias alternativas. Interesa la opinión de la doctora sobre la PNI y la incidencia del tipo de nutrición en el desarrollo de la ELA.
Psychoneuroimmunology is it's really interesting. We don't know. There's a lot we don't know about the immune system, but I think there is a kind of implication in that question, maybe, that if we change our psychological attitudes, that we can change our immunological profile, and that in some way might change how our disease progresses. And I don't think there's any evidence to support that. So I think psychoneuroimmunology is it's a nice phrase. It has to do with how our hypothalamic pituitary axis changes in times of stress, and how that affects how our immune system operates. But the immune system is really, really complicated. And I think that, just saying that, if we have high levels of stress, that will change our immune profile, that might be true. But exactly how that happens and what are the factors that do that, I think that's too early and too complicated to discuss. And to say how that might change a disease pattern, I think the evidence is not supportive of that at the moment. So I just mentioned that there's a lot of evidence now that weight loss is not good in ALS, that people who lose a lot of weight tend to have a poorer outcome. That might be the disease itself. We know that some people with ALS are what you call hypermetabolic, so their metabolism is just sort of driven much faster. There, as I said, there is a study from Germany that suggests that very high calorie supplementation improves outcome. So I think we should look at that study very carefully, because I think it's a very interesting finding if it's true. I think all ALS centres would certainly advise their patients to change their dietary habits immediately, and to increase their content of high fat, high protein, high carbohydrate diets. I think most centres would recommend that, particularly high fat diets. So I think there is a lot of evidence now to support that. And as I said, there's a trial that I'm not sure it's published yet, but that's been reported to suggest that as well.
Si se sabe algo, ¿qué beneficios puede tener el aceite de cannabis sobre la persona con ELA?
I think the answer is we don't know. The cannabinoids are a really interesting group of compounds, and certainly have neuroactive properties, and so lots of people are looking at this. For the alternative therapies, I would recommend the ALS Untangled site. So Richard Bedlack in the US is the curator of that site, and the cannabinoids are actually discussed on that site. It's a little bit old now, I think, the cannabinoid work, but that's a really good site for alternative therapies. And you can actually put in a request for Rick to look at any compound or treatment that you think is worthy of discussion, and if there's enough people looking for that, he will do it. So it's a really good site. It's called ALS Untangled.
Yes, a note on that. We always recommend that site, and we are usually in contact with Rick, and he is actually giving a talk, teleconference for Argentina on June the 12th.
Yeah,
So
it's a very, very valuable service that he provides. Yeah.
Es importante saber el tema de terapias alternativas, que cualquier persona que presente una evidencia de mejoría en cualquier terapia alternativa tiene que someterla a una revisión científica. Esa es la respuesta generalmente de todos los científicos. Que no quita que cada uno haga lo que quiera, en el respeto de entender que cuando la ciencia no tiene una respuesta al misterio de la ELA como ahora, cada uno haga lo que le parezca y le plazca. Pero bueno, nosotros como asociación estamos alineados en esa posición. Estricta rigurosidad científica, fuentes confiables, evidencias comprobables y además no cerrados a escuchar terapias alternativas, pero que sean revisadas, en este caso, por el grupo de científicos que lidera la ALS Untangled con el profesor Bedlack, que son 100 científicos de 10 países diferentes. Nada, me parecía que era importante explicarles esto también.
Hace unos días leí una información de España donde se habla de una investigación con una proteína protectora que llaman neuregulina, que volvería más lenta la progresión de la ELA. Quería preguntar si la doctora tiene alguna opinión sobre esa proteína, neuregulina. Gracias.
Yeah, so that's animal work. So it's a really interesting observation, but it's based on animal work. So we don't know how that relates to ALS at the moment in humans. It's interesting because it's a compound that changes neuronal development, and it's also a gene rather that changes neuronal development, and it's also a gene that's seen implicated in schizophrenia. So that's kind of interesting because we've seen an association genetically and also in epidemiology between ALS and schizophrenia. So it's interesting in terms of the biology of what might be happening in some forms of ALS, but how we draw that out into where we go for next treatments, that's too early to say, I think. It's an interesting observation.
I would say the last two things that I will ask you is if you can make a summary of promising treatments that are in phase 3, I would say, because we have a pretty long list. We had a pretty long list for 2020 and 2021. For example, we were expecting results of methylcobalamin in March that we don't know if those results came out or not. Besides that, any other research that is already in their final stages that you can talk about for the next months, I would say, or the next couple of years?
I think that's a really difficult ask, actually. I mean, I think the easy answer is the genetic studies. You know, that's, I think, what most of the big companies are really interested in developing treatments for the genetic forms of ALS. So that is going to report out in a really meaningful way, I think, quite soon for SOD1, and then the C9 a little bit further down the line. And then there's a pipeline of new therapies for other genetic variants, ataxin being one. So I think that's definitely, we're going to see very significant reporting on those, and I think it's going to be very exciting. In terms of drugs that look very, very hopeful, it's hard to select out big sort of what we would call kind of blockbuster. We don't have a sort of big dexpramipexole study like we had in 2013, with 900 patients. There isn't a big study like that going on at the moment. But there's lots and lots of smaller studies, and it may well be that some of the studies that we're doing in the TRICALS group, possibly the new Edarabon study, the TRIMEX study, which was a phase 2 in Australia, open label, starting a phase 3 now in Europe and in the UK. That looks, that's the anti-HIV drug. That's looking, I think it'll be valuable to see that what the outcome of that is. We don't know yet, but the phase 2 looked interesting. There's the TUDCA TUDCA that's underway in Europe at the moment. We're about halfway through that. It's a phase 3, but there's a TUDCA as part of a compound that's reported out in the US, in a small company. So that's worth looking at as well. It just reported recently, and it was a combination of TUDCA and phenylbutazone. So that's worth looking at. It looked like it was positive. We know that masitinib reported out as positive, but that there were some difficulties with the governance of that study, and there is a study that is being planned. There are some protocol issues that need to be resolved in that study before it's underway. It's sponsored by AB Sciences, but that's a compound that looks interesting that I think we need to pay attention to. And then if you go on to clinicaltrials.gov, there's about 350 studies underway at the moment. From small centres to slightly large centres. The Niels group in the US has many compounds that they're undertaken with small phase 2 and hoping to lead into phase 3. There's a phase 1 study underway in Canada with a compound called enoxacin, which is a really interesting compound because there was a paper that came out in just December suggesting that enoxacin had an effect in animals, and that the biological reason behind that would also be of value in human disease. And enoxacin is what we call a repurposed drug. It's an antibiotic that's been repurposed. So there's a study just starting in Canada with that compound. So I think what I'd like to say really is that back in 2013, when we had a big study across many centres in Europe and the US of a drug called dexpramipexole, which there was a lot of optimism about, and the study was negative. It created a huge amount of despair within the field. So that's almost 10 years ago now. And for a couple of years after that, the field of ALS drug development was essentially moribund. There was nothing happening, and it didn't look like anybody was very interested in ALS. And then about 2016 or 2017, things started developing again, and it was partly to do with gene therapies. But now the field is really exciting, and there's a very large pipeline of new compounds in either preclinical or early clinical phase. Over 40 is what one of the CROs said to me. So the CROs are the clinical trial organizations that help to run trials. So one of my friends works in a CRO, a very big CRO, and she told me that there's over 40 compounds that are in early phase, 20, even closer. So there's scope for lots and lots of optimism. I think what will happen is we will be probably thinking more along this kind of precision medicine type of approach. The trials that we're going to do going forward are going to not only tell us about whether the drug works or not, but they'll tell us a bit more about the disease. So every study that we do, we build in some additional information that we want to learn about the condition as well. So even if the study is negative, the work that we do in undertaking the study will give us more information about the disease, and that'll make us better at doing the next study. So it's a really exciting time. I'm coming to the end of my career now, and I don't want to retire, because I think the next few years of what's happening in the field are going to be really exciting, and they're going to really help us to, bring the field to the next generation, where we'll be finding, drugs that where we'll be building on drugs that are working to make them work even better. So I think it's a good time. It's a good time to be in the field. It's a good time to be attracting young people into the field, because I think we're nearly there. I think we really are nearly there.
That's really good news. Yes, please, Orla, don't retire. You're still young. Come on. We still need you. Okay, Orla, that was great. This is a major contribution for us. We really, really want to thank you. We are not an association of researchers, but we do promote research a lot. We have been organizing conferences in Argentina, in-person conferences when it was possible. You know that Amar came here, and also Lucy Bruin, and John Glass, and Dr. Yoshino from Japan also visited our country and gave a couple of talks. And well, last year we have a teleconference with David Taylor from Canada, and again now we're doing this with you, and next month it's going to be.
So can I make a recommendation to you guys that I think what you need to be focusing on is building your talent locally. So we have the LANALS group, the Latin American ALS consortium for epidemiology. So we want to have all the countries in Latin America participate in that collaboration. So it's currently Uruguay, Chile, and Cuba, and it's funded by the CDC. And we're coming to the end of the study we were doing with those three countries. But what we want to do now is build out on LANALS to all of the Latin American communities that are engaged in ALS research. We have a database that we are happy to share with you, and to collect information on patients from an epidemiological point of view. And we would like to build on the LANALS consortium to a point where you don't need us anymore. So we want this to be eventually owned by the people in Latin America for Latin America, to build the epidemiology and clinical research in your countries, so that you can participate in trials and understand the disease in your own areas, and you don't need people from other countries to come over and tell you, because you'll be sending people over to us to tell us. So I think that'll be really good. So I can send you the information about LANALS, but it's something that we really want all the other Latin American countries to work with this group, and to build a really nice mirror of what we have in Europe with NCALs and TRICALs, and that they have in the US with NEALS, so that there's a nice consortium of centres across Latin America that are working together And the way you start that is with epidemiology, I think, with the network through epidemiology. So we have a few more months of Lena's. We were planning to be in Uruguay this last week, actually, but the COVID virus prevented us from doing that. But there will be some more meetings once we're allowed travel again. We will have some additional meetings. We were also planning to go back to Chile, but because of the political unrest there, it's been difficult for us. I think they have their elections this week, actually, but there's difficulty. There's been difficulties there, but we'd really like the groups in Argentina to be part of this, and also the groups in Brazil to be part of this. And there are others, a group in Colombia, there's a group in Costa Rica, up in the Caribbean. There are many groups that I think we need to tie in together as a larger consortium, I think.
Yeah. Okay. Lastly, any message you want to share with our ALS community in Argentina? No, you have a final message?
Yeah, I think, stick with your ALS centers, stick with your ALS doctors, support your ALS doctors, if you need to fundraise for ALS research. But I think, Ireland is not a very rich country. We were able to bring ALS into a European standard by working hard with our ALS association. I think it's really important, and I think it is really valuable to continue to build the ALS centres in Argentina and to work really closely with the ALS Association in Argentina.
Okay, Orla, thank you so much.
You're very welcome. I'm really sorry I couldn't do it in Spanish. I feel so embarrassed.
No, that's okay. Then most people in the northern hemisphere that don't speak Spanish, so that's okay. We speak some English here, so I'm looking forward to seeing you maybe soon. It's not going to be in Montreal, unfortunately.
No, virtually in Montreal, but hopefully in the next year.
Maybe virtually. So this was great. I think you cover all the topics. So once again, on behalf of the ALS Association of Argentina and all the community here, thank you so much.
It's my great pleasure, and I'm sorry I haven't been there. I love Buenos Aires. I was there last year. I love it.
Yeah. We were trying to get you here, and Leonard and some other folks, but maybe next year. Maybe next year. And again, thank you for your time and for your patience, and we will be in touch. Okay.
Okay. Great. Okay. Thanks very much. Okay. Bye now. Bye.
Thank you, Orla. Thank you so much.
Okay. Bye.